Pleural effusion. This is one of the short cases that will be given in exams for the final year MBBS. In sometimes it can be given as a long case also in case of non-availability of the CVA cases. But maximum one pleural effusion cases will be there for almost all the students. Chief complaints. So as with any other disease, there are some complaints that are pertaining to pleural effusion alone. One such is cough. Patient will be having cough, and this cough in pleural effusion per se will be dry, will not be productive. The mechanism will be dealt in a later slide. So first and foremost complaint will be patient will be having dry cough. One another condition where you will get this dry cough is interstitial lung disease, that is pulmonary fibrosis. Next one is fever. You can get fever. Actually pleural effusion is broadly divided into transudate and exudate. Transudate occurs when there is problem in the imbalance between hydrostatic pressure and oncotic pressure. Either an increased hydrostatic pressure in the pleural capillaries or decreased oncotic pressure in the pleural capillaries can cause pleural effusion. As with edema. Edema, there are only two mechanisms: increased hydrostatic pressure or decreased oncotic pressure. In the same way, pleural effusion can occur also due to imbalance between those two forces. In such cases, it is called as transudate. When there is inflammation of the pleura, here there will be no inflammation of pleura. When there is inflammation of pleura, it results in exudative pleural effusion. In case of exudative pleural effusion, you can get fever. Remember, fever is not a feature of transudate. Next complaint will be dyspnea. This dyspnea can be due to two mechanisms. One is due to the pleural effusion compressing the lung, resulting in collapse of the lung. This is one mechanism. Other one is the pleural fluid can cause inversion of the diaphragm, which you will see in the later slide. These two mechanisms can cause dyspnea. And next is pleuritic chest pain. As already said, like fever, this pleuritic chest pain is also a feature of exudate. In transudative pleural effusion, you will not have pleuritic chest pain. And loss of appetite can be there if there is underlying tuberculosis or malignancy. And evening rise of temperature is pertaining to tuberculosis. Cough. Coming to the cough, as with any other disorder, this has to be described as the number of days the patient is suffering from cough, whether the cough is dry or productive. In our case, it will be mostly dry. Suppose if the patient has underlying pneumonia, patient can have productive cough also. If there is underlying tuberculosis, he can have productive cough also. So pleural effusion per se will cause dry cough, but when there is underlying disease that causes pleural effusion, you can get productive cough also. Mechanism of production of cough is, consider this as bronchial wall. This is one bronchus with two walls, and the center white is called as the lumen. So anything which goes and sits on this bronchial wall will be considered as a foreign body and will elicit a cough reflex. Cough is nothing but a protective reflex which clears the airway of secretions or foreign bodies. So in case of pleural effusion, the bronchial wall, rather than being like this, goes in for opposition. That is, the bronchial wall will touch each other, and this bronchial wall will consider this bronchial wall as a foreign body. Though it is the bronchial walls that are touching, they will consider the other bronchial wall as a foreign body, and there will be elicitation of cough. This is the most commonly accepted theory behind cough in pleural effusion. Next, the patient can have fever. It can range from low to high grade, mild, intermittent or remittent fever also. If patient fever can be absent if the patient has immunocompromised, children, elderly or in septicemia. Dyspnea, as we said, always rule out cardiac causes by asking about orthopnea and PND. And there are two mechanisms. One is the lung gets compressed, lung goes in for collapse. Next one is, this is the right diaphragm and this is the left diaphragm. Normally the left diaphragm will be in a lower level and compared to the right diaphragm. Suppose the dome of diaphragm will be like this. In case of pleural effusion, the central part of diaphragm goes in for inversion because of the weight of the fluid. So it will not be able to contract properly. When the diaphragm is not able to contract properly, the lung cannot expand as expected. Hence, this can result in dyspnea. These are the mechanism begins dyspnea. And chest pain, it will be pleuritic. Remember, as with fever, this chest pain, that is pleuritic chest pain, otherwise called as pleurisy, is a feature of exudate. Transudate will not cause fever, will not cause chest pain. That too, the parietal pleura is only pain sensitive. Visceral pleura is always pain insensitive. This pleural pain will be getting aggravated on deep inspiration, because on deep inspiration the lung expands to the full capacity, thereby bringing the two walls of the pleura in close proximity. So when the two pleura rub against each other, patient will have pain, and also when the patient coughs, he will have increase in the pain intensity. And this chest pain will be relieved when the patient lies on the same side. Suppose if I am having a right side pleurisy and I lie on the same side, my thoracic movement on the right side is hindered. That is, the thoracic cavity of the left side will expand normally, whereas that on the right side cannot expand fully. So when the lung cannot expand fully, the pleural, there will be no rubbing of pleura against each other. Hence, lying on the same side will relieve me of the chest pain. And pain will disappear when the patient develops effusion. Suppose if the patient has started an exudative pleural effusion and the pleural fluid accumulates day by day, this pleural fluid will result in the separation of the two layers of pleura. As a result, there will not be any rubbing of pleura against each other. Hence, the pleural effusion can make the pain disappear. And this pain will typically respond to opioids only. Past history, ask for similar history in the past. Personal history, ask for any adverse social habits, diabetes, hypertensive, bronchial asthma, COPD, diseases, etc. And general examination, consciousness. As far as pleural effusion is concerned, pleural effusion per se will not cause any loss of consciousness or altered sensorium. And orientation, you can check. Temperature, check whether the patient is febrile. Febrile with pleural effusion, always rule out exudative causes. Always think of exudative causes. Transudative effusions will not have fever. And pallor, look if the patient is anemic, because anemia can cause CCF, congestive cardiac failure, and this can cause a transudative pleural effusion. And icterus, to rule out any underlying liver disease, because liver disease can cause hypoalbuminemia, which can cause pleural effusion. This is one thing. And another thing is, the most common cause of pleural effusion in our part of country is tuberculosis pleural effusion. We will be giving anti-tuberculosis drugs, of which most of them are hepatotoxic. Suppose if the patient has pre-existing liver disease, your hepatotoxic drugs can add fuel to the fire. So you have to monitor for that also. And cyanosis is very rare, and clubbing can be seen if there is suppuration, that is empyema, pus in the pleural cavity. Suppurative lung disease can cause clubbing. All suppurative lung diseases are bronchiectasis, lung abscess, and empyema. And look for pedal edema also to see whether the patient has some imbalance in the hydrostatic and oncotic pressures. And look for generalized lymphadenopathy, because this can indicate either patient may be suffering from HIV or lymphoma like thing. And watch for the BP, pulse rate, respiratory rate, temperature, and JVP. JVP will be normal if the patient does not have any cardiac disease. It will be elevated if the patient has cardiac diseases. Coming to the inspection, the upper airway and lower airway aspect to be inspected. Upper airway, you have to check for the nasal septum deviation, whether there is any polyps, turbinates, hypertrophy, and look for the posterior pharyngeal wall for any postnasal drip, and tonsillar enlargement, which could be a part of lymphoma. And oral hygiene, poor oral hygiene can predispose to microaspiration, which can cause lung abscess, which may rupture into the pleural cavity producing empyema. And trachea will be always shifted to the opposite in case of pleural effusion. This is one lung and this is another lung, and the trachea is in the middle position. Suppose if there is accumulation of fluid around this lung, it will push the trachea to the opposite side. So pleural effusion always pushes to the opposite side, but this may not be seen in almost all the cases. Sometimes the trachea can be in the midline also. What could be the possibilities for a trachea to be in the midline? One, the pleural effusion will be so minimal that it does not exert any pressure on the trachea. So in case of minimal pleural effusion, my trachea will not shift to the opposite side. This is one condition. Next, patient might have had bilateral pleural effusion. This side also the patient will be having pleural effusion. This side also pleural effusion. So as a result, the trachea will be in the midline only. Next, if the mediastinum is fixed due to some underlying causes like mesothelioma, your trachea cannot move. So these are the causes for pleural effusion with the trachea in the midline itself. There are some conditions where you can get trachea shifted to the same side in case of pleural effusion. Suppose this is a bronchus. Suppose there is some endoluminal growth which obstructs this bronchus. As a result, this lung goes in for collapse. So the two layers of pleura are getting separated. As a result, there will be increase in the negative pressure, which sucks the fluid from the parietal capillaries. So, in case of collapse of the lung due to endoluminal obstruction, there can be a pleural effusion. In such cases, the trachea will shift to the same side. And also look for the symmetry of the chest and accessory muscles of respiration. And apical impulse may not be visible if the patient has left-sided pleural effusion. And look for the intercostal fullness, dilated veins, scars, and sinuses. Palpation, you have to confirm all the inspectory findings and look for the position of the trachea using 3-finger technique, and look for chest expansion, apical, anterior, posterior, and decrease, and measure them with the inch tape also. Measurement has to be done at the level of nipple in case of male and just below the breast in case of females. And VF will be decreased because pleural fluid, consider this as lung and this is your pleural cavity. You are placing a steth here to auscultate. Sound is produced here. This pleural fluid will not allow this sound to be heard. So VF, VR and breath sounds all will be decreased in case of pleural effusion. Percussion, you have to percuss in all this region, supraclavicular, direct percussion of the clavicle, and look for the stony dull note. Auscultation compare on both sides. Breath sounds will be either diminished or absent in case of pleural effusion, and just above the level of pleural effusion you can get these two findings, that is the findings of consolidation, that is bronchial breath sounds and egophony. And VR, as we said, rarely it will be decreased. And you have to examine the other systems also. You have to finally make a diagnosis of case of right-sided or left-sided pleural effusion, probably due to tuberculosis or the etiology you have to mention. And these are the investigation that has to be done. First, you have to measure the CBC. You have to do a renal function test, liver function test, take in chest X-ray, and pleural fluid analysis. All these things should be done. Next, you have to after doing a pleural fluid analysis, classify the fluid as either a transudate or exudate by applying Light's criteria. Actually, it is LIGHTS, Light's criteria. And examiners may also ask about the causes for predominant right-sided pleural effusion and left-sided pleural effusion, and also the test to diagnose tuberculosis pleural effusion, and how to approach a case of milky white effusion and blood stain effusion. These last two will be dealt separately. And in CBC, look for whether the patient has anemia, and total count, if it is elevated, it indicates some infectious process. And differential count, if neutrophil is increased, it indicates an acute process. If lymphocyte is increased, it indicates a chronic process. And eosinophil, if it is increased, it indicates some allergics. And RFT, because dose adjustment has to be done in case of renal failure, you have to measure the urea and creatinine before starting any drugs. And LFT, look for the baseline LFT to see whether the patient has any pre-existing liver disease. And chest X-ray will demonstrate this phenomenon, which is called as Ellis's curve. You can see normally any fluid will assume a horizontal straight line, but here you can see it is curved with the apex in the axilla. This is called as Ellis's curve. Actually, this is called as a radiological illusion, which also will be dealt later in a separate slide. So, in case of pleural effusion, you can get this Ellis's curve. There are two angles in chest X-ray. This is one angle, that is cardiophrenic. Phrenic means diaphragm. Cardiophrenic angle and costophrenic angle. Pleural fluid first accumulates here. So, blunting of this CP angle, costophrenic angle, is the first radiological sign in case of pleural effusion. And pleural fluid analysis, all pleural fluid analysis should begin with classifying the fluid as whether it is an exudate or transudate by applying Light's criteria. Here you have to measure the LDH and protein in both pleural fluid as well as serum. Actually, there are three criteria: pleural fluid protein to serum protein. If it is more than 0.5, it indicates exudate, and LDH ratio, if it is more than 0.6, it indicates exudate, and if the LDH is more than 2/3 of the upper limit of normal cellular value, it indicates exudate. Actually, there are three criteria. Remember, all three must be satisfied to call it as a transudate. Even if one is negative, you can call it as an exudate. Suppose if all criteria are satisfied, that is all are negative, it is a transudate, which means there is no problem with the lungs or the pleura. The problem is either in the heart, liver or kidney. So you have to search somewhere else. Suppose if it is an exudate, then further you have to test the fluid for cell counts, sugar, etc. And while tapping, this is one rib, this is another rib. Remember, in between the rib you have the vein structures, that is intercostal vein, artery and nerve. So the needle should be inserted here, that is the upper part of the lower rib, in order to prevent damage to this neurovascular bundle. And these are tests done to confirm tuberculosis effusion. Tuberculosis effusion, first there will be an exudative pleural effusion in which lymphocyte will be predominant cells, and ADA stands for adenosine deaminase. It has more of negative predictive value. A value of more than 60 indicates that the pleural effusion might be due to tuberculosis. Value of less than 40 virtually rules out tuberculosis. So it is here the negative predictive value comes. And interferon gamma can be measured, and pleural biopsy is the confirmatory test to where you can demonstrate case-sheeting granulomas. Kindly note, the effusion in tuberculosis TB is not due to the AFB entering into the pleural cavity. So AFB will be seen in only less than 5% of the cases.